Welcome again, everyone, and I'll put this in presenter mode. So it's really such a great event. I think this is extremely innovative, and we are lucky to be all together here. So this session is about migraine and its impact in the workplace. This is really something I deal with a lot in my practice, in all kinds of different ways. And so to start this discussion, I will take my favorite doctor here, Dr. House. Doesn't he look lovely and welcoming? Because some people just discard migraine. They make three assumptions about this condition. They say it must be psychological because there's no objective science. And I think we talked about that in the first session about the science of migraine. They also take for granted that migraine is just a headache and therefore it is benign. So it cannot have an impact on work. And sometimes they also think that if it's not treated with Advil, well, there's no potential for improvement. All of this is, of course, wrong. And this is something that we have to talk about with people in the workplace. So, objectives for the next few slides and next 20 minutes or so. I was going to share some data about the impact of migraine on work because experience is one thing, when you know about what happened to you. And I certainly hear tons of stories in my office, but research and published data is important. If you speak with a corporate person, a CEO, or someone who manages an insurance company, you need some hardcore numbers. And then I'll say a few words about, how to adapt the workplace if you live with migraine, and a few words also on the disability aspect of migraine, which is quite complex and something we really need to work on. So, who has the data has the power. It's in this world, it's very important to share one's experience. But data is more and more important, and we actually have the power to gather more data. So research is something that we need when we speak with people who make decisions, policymakers, and then business owners. So I'll show you a bit of data about the impact of migraine on work. Let's start with the World Health Organization, a very renowned institution. Every whatever years they do a big survey about the burden of disease, and they look at all diseases. They don't only look at neuro or pain or migraine. This is
I'm gonna get you to pause for a sec. Your slides aren't
for
moving.
sure. Oh, I'm sorry.
In full screen again and try that.
Yeah, just a minute. It's like sharing is paused.
It's paused and locked.
Paused and locked. Okay, so I'm gonna stop sharing and then start again.
Perfect.
Hopefully that settles it. Apologies, everyone.
Excellent. Thank you.
And now it looks like it works. Okay, so I'll take it from there. Just a minute. All right. Does it move now?
Perfect.
Yes. Apologies, everyone. So, and thank you for catching that. So, the World Health Organization in 2016 just noticed that, researched all diseases and said that migraine is actually the third most common disease in the world. After the first is dental caries, the second is tension type headache. So, it's extremely common. And it's not only common, it's also disabling. So, it's the second cause of years lived with disability. And why is that? Was because there are so many people affected. The attacks are very disabling. And then it affects people over many, many years of their productive lives. A lot of people with migraines start when they're kids or teens or young adults, and it can go on to 50, 60, 70. Migraine does not stop at menopause. It usually it can improve, but it's not rare to see migraine affecting someone until their later years. So this has a huge toll on the capacity of someone to work. So the World Health Organization, once again, does recognize that a severe migraine attack is as disabling as acute psychosis or being quadriplegic, so being paralyzed. And no surprise, you cannot use your brain, you cannot interact with people, you cannot concentrate, and you are in the dark room and you might be actually vomiting or being extremely sick. So a severe migraine attack can be very disabling. Not all migraine attacks are severe, but some definitely are. So we also have to put things into context, because when we focus on, we are healthcare providers, you might be someone living with migraine, and we see the most severe end of the spectrum. But we have to look at it from the perspective of someone who's a business owner, an insurance company. And it's true that it's a fact that the vast majority of people with migraine have low frequency of attacks. 80% of people with migraine live with 6 or less days per month of headache. And this is why people might not perceive migraine as a potentially disabling problem. But then, of course, the 20% that remain that are higher episodic, so more frequent attacks, or chronic, very common attacks, maybe no headache-free days in a month, these people can be severely affected. But I think it's important to remember, when you do not live with migraine, you might have a different view on things. The burden of migraine in money and kind of dollar sign is difficult to quantify. I put here an estimate from a study in the US. We do not have strong Canadian data. We do need data. I mean, we're a big country. We're rich and wealthy and able. We should have more research done on this. And the burden of migraine comes from the medical care. And this is probably underestimated, because undertreated, because people with migraine do not have access to care in this country. I mean, this is, if I compare to other countries in the world that I visited or trained in, Canada is not a Nobel Prize. I mean, we are not top leaders, and I think we can and must improve. So medical care probably doesn't cost that much. Absenteeism is when you actually miss a day of work. You do not show up, you're not there. And presenteeism is when you are there, but you cannot do your work normally. So you're slowed, you cannot focus, you cannot concentrate, you might need a rest. So employers and insurance companies should care about migraine very seriously. So let me show you more data here. So this is a study that compared epilepsy, chronic migraine, and episodic migraine. Episodic is in bright yellow and chronic in red. And it really, it just jumps to your face that the majority of people with epilepsy have no impact on work. And the majority of people with chronic migraine cannot work at all or work part-time. So the burden of this disease is extremely significant. More data. Here, this is a data on presenteeism in the US, and stating that you can see migraine in the red here as minutes or days lost per person, and then the annual company costs. And migraine comes very high compared to other well-known diseases such as depression, arthritis, diabetes, asthma, and so on. And one last piece of data, just to, and this is actually important, so you know there is data to back this claim that migraine is disabling, because sometimes people will say, or you say it because you have it, but this is kind of hard, cold numbers. Here are reports from the Integrated Benefits Institute comparing different chronic disorders, depression, diabetes, back pain, and rheumatoid arthritis, which is very rare compared to migraine. But you can say that if we look at sick days, short-term disability, and long-term disability, well, the ballparks are very similar. So migraine is along these others regarding the sick days and short-term and long-term disability. So it should be on the radar on insurance company and employers. And let me tell you, it's not. So I think there's a lot of work to do there. Migraine Canada actually looked at this, and we did a survey for advocacy purposes. And then we looked at people. You can see right away, looking at the graph on the left side, that people with chronic migraine are more represented in our survey compared to the graph I showed you before. And there's no question that, when you're more severely affected, you're more likely to engage in an association or to seek help. So that makes a lot of sense. So patients had a third of episodic, chronic, and then low frequency or high frequency episodic. Half of these people were working full-time, and others were retired or were working at home by choice. So let's look here, and you don't have to read all of this, but it's just to tell you that on this scale, which is kind of a Canadian creation, going from zero is perfect. You have no limitations in your personal or work life. 10 is being disabled and dependent on someone. So you need someone to assist you in living. So the first three are really like you need to avoid triggers. You may miss personal activities, but your work is fine. So this is very few people in this survey. The majority of people, actually 60%, are in the kind of yellow, blue, and green, or 3 and 4 and 5 categories. They work full time, and either they miss personal activities and they are delayed or they cannot perform, or they miss maybe 1 or 2 days or maybe 3 days per month of work. So that's actually quite a significant impact. And then we looked at people working part-time, so that's 6%, and 13% are disabled because of migraine. So this is really showing that the impact of migraine on work is diverse and sometimes quite severe. So this really puts us to two situations. Situation one is if you live with episodic migraine or maybe milder chronic situation. So you have specific triggers and you can actually work, but you might have some presenteeism, a few days missed, but you're able to work. So you might actually improve your quality of life by discussing accommodations with your employer. The situation two is if you have more severe migraine, everything is a trigger, like your migraines are very, very frequent. And then full-time work or even work at all is impossible. And then you're considering short-term or long-term disability. So the first situation about episodic migraine, it really puts in front of us the concept of episodic disability. Employers and the working place thinks like healthy or disabled. You can do it or you cannot do it. There's no flexibility. It's very difficult to be flexible. So it doesn't apply well to migraine, which is a paroxysmal disorder. You can be completely disabled for a day or two, and then poof, you're super good for the next 28 days of the month. So this is something that employers have difficulty understanding. But epilepsy and multiple sclerosis also come with episodes, but the frequency of the episodes is usually way lower in epilepsy and multiple sclerosis than in migraine. So for situation one, there are common triggers in the workplace, and you might be aware of many of these: scents and smells, the posture, the workstation, strong lights and noises, computer glare, difficulty having regular eating and drinking. Shift schedule is terrible. I follow a lot of people who work with shifts and night shifts, and that's really tough for people with migraine. And emotional stress, of course, it can be a relationship with the difficult clients, for example, or teamwork, or a difficult boss, and so on. So in life, you don't necessarily get what you deserve, but or you want, but you can get what you can negotiate. And so this is where building a list of reasonable accommodations for people with migraine could be advocated for. Things like a no sense policy, in the workplace, better lighting, avoiding different lights like LED, for example, that some people do not tolerate, having a noise protection, having a good workstation, having mini breaks, appropriate access to water. Right. I remember a teacher who told me she could not hydrate because then she would have to go to the bathroom and leave her class with her students. And so that was quite interesting. I mean, it was a problem for her. No night or irregular shifts. That's sometimes difficult if you are in the healthcare system, for example, and you're starting as a young nurse in the ED. This is very tough. Flexible schedules, work part-time, and telework. The pandemic, nobody likes the pandemic, I think, but the telework has been, for some of my patients, a blessing because they save time in transportation and they can adapt their work environment, and they might have also some flexibility. So maybe the pandemic will have opened our eyes to the possibility of telework, and we'll see how that applies to people with migraine. What about toxic places, like toxic workplaces, stressful? I mean, not everybody lives in like a garden with very nice people who all smile and are happy, right? Sometimes it's stressful and the pace of work is not sustainable. We live, in a society where there's a lot of performance. You're expected to answer email at any time and so on. So that's where we use all the techniques you've heard about pacing, about learning to say no, setting boundaries, prioritizing, getting support from others as well. And then avoid negativity or avoid emotional drains. Practice relaxation techniques and consider CBT, occupational therapy, life coaching can be very good too. And sometimes I'll say it. I have patients at some point, I had a discussion and And the person said, maybe I need to change my job. And I said, well, you know what? Maybe you should. And they were happy with the change. Change is always difficult, but sometimes it's actually the right thing to do. So, and the last thing is for this situation is, of course, please see a medical provider and make sure you have access to all the right treatments to make your condition better. And I think you've learned during this event that there are many options for you. Situation 2 is chronic refractory migraine. Your life, you're barely able to do your daily activities. I hear patients about, struggling to take care of their children, having difficulty driving the car, reading, doing whatever, even things that they really love to do. They cannot do them anymore, cooking. So just daily activities. Some people are severely affected, and it's very tough. So, we saw Yoda in the first talk, and here he comes again. So he says, calm you shall keep, and carry on you must. So I think a lot of my patients are Jedi masters. They learn the techniques, they do the pacing, they really are very, very wise and resilient. And I think this is something important to say, because some people think that migraineurs are lazy or wimpy or weak, and nothing is more wrong. I will say this: after 12 years of working with people with headaches and migraine, I see people who are extremely strong. So this is really a tough situation. But despite all of this, well, here's House again. Migraine is not recognized as a long-term disability. I know more about the US, and so migraine is not listed in the Social Security Blue Book for list of impairments. It's not recognized as a chronic disease. In Canada, it is not on the list of chronic diseases where you find diabetes, asthma, and other things like that. And so the terrible situation happens when people have to use other diagnoses, for example, mental health, like depression, to get disability recognized. And all of this is because migraine is invisible. There's no proof. And people say, like a neurologist expert can say, oh, this person has a normal examination and a normal MRI, therefore there is no problem, they should be working. So there's a lot of work to be done here, and it's an elephant in the room. So migraine really takes a toll on personal and professional life. There's a cost, there is money here. There's a cost to employers and insurers. And we can improve the lives of people with migraine, and give them back their capacity to live, but also to work and contribute to society with the skills that they have and learned. So tips, clarify your situation, have a headache diary, define your goals, discuss with your employer, try to find reasonable accommodations, and be aware of your rights. I'll conclude about that later, because I'm not too sure about the rights and the legal part myself yet. Discuss with your physician. If you need letters, I sign letters very often. You have to find kind of something that makes sense and is acceptable to the employer. But sometimes a little letter from a neurologist can go a long way. And optimize your medical treatment so you're sure that at least you're in the best place medically. So future actions, in conclusion, for us at Migraine Canada, we have a lot to do. We need information on disability laws for patients. If you have knowledge in this field, please reach out at info@migrainecanada.org, because we want to provide support to navigate the system. We can educate people, employees in the workplace. We can also educate other employees who do not live with migraine, so they can help and support people with migraine better. We need to educate people in HR departments, and then advocate with insurance companies, so the disability companies, so they recognize migraine as a disability, and also with the companies who provide drug coverage, so we make sure that they offer coverage for treatments for migraine. And then we need Canadian research. I was so glad to see people like Susan at the beginning doing her research in Canada, so we can show that, like the cost, the burden, Canadian numbers, and also that treatments improve capacity to work, and it's worth supporting patients on their journey to relief and improvement. So thank you very much. And I hope that you find ways to navigate this. I'll tell you, it's absolutely not easy, but it can be done. And we will work on this with the Migraine Canada team. Thank you.
Awesome. Again, Liz, such an advocate We've had a few questions coming in, specifically about return to work in insurance companies. One of the biggest questions that came in several times: how do we increase the knowledge and awareness of case managers and insurance companies for patients who are struggling with migraine? And I'll add to that. How do we improve the knowledge of our IME physicians who are doing these private assessments, who are often advocating against supporting these patients?
So I think what we need is a very strong presentation and speakers, and go and knock on doors and say, okay, we're Migraine Canada and we have a wonderful 45 minutes talk to present to you. And this has to be strongly supported by publications and data. This has been done in the States there's a lot of advocacy going on in the States. It's been done in Italy. So in Italy, migraine has been put recently on the list of chronic diseases. So it's a lot of work on the ground. So we are looking for volunteers, but beyond that, we need to really get a strategy, because those are long hauls. It can be done, but it requires people to one by one, through conferences, education modules, so we can provide this data. The data is partially out there, but it needs to be disseminated. And you can believe me that employers and insurance company are not going to come to us to ask for it. We need to go to them.
Yeah, good call. I 100% agree with that. And ground level advocacy is often where we have to start. I know, Liz, you're not shy of the media and advocating there as well, which I think is another big piece for us to be at. There's no question that trying to get into kind of these private assessment physicians and private assessment companies is a big piece to increase their understanding. If you think migraine is bad, chronic pain is just as bad. I once had an assessment that I read where an orthopedic surgeon called the person's pain psychic pain. I had to remind the orthopedic surgeon, we're not talking about tarot cards and crystal balls here. Anyways, there's a lot of problems. They're often elderly docs that really aren't on top of what's going on today.
But I think you just need stories. I'll share this because you guys who are listening, and I know not everybody responds to therapies, but the reason why I'm doing this work and I love it is because you see people responding to treatments. And they go from someone who cannot function to someone who's fully functional and say, yay, I can actually work better and live my life. So when you see this, and now we have all, the CGRP data and the information about the science of migraine. So we are now on a very solid ground to defend migraine as a condition. So it's the science has brought us like really forward. And I feel way more confident now going to an insurance company than I was 10 years ago. So I'll thank all the researchers who provided us with science and treatments that can help people.
Brilliant. It's unfortunate that we have to prove anything, but it is what it is right now. Next question. Can you give some examples on how to build empathy and work modifications when speaking with an employer insurance company? Is the data you presented available online?
Not yet, but we hope to actually put it in formats that we can share with you guys, and you can bring this data to your employer and insurance company. There's a lot of work to be done, and that's exactly what we want to do, is to save you the work by kind of doing it and then sharing it with more people. I'll say this, that when you negotiate, this is true for any situation, you have to try to be calm and respect, because sometimes emotion gets in the way and it becomes not very productive. So whatever you do with the employer, I think it has to be based on like science and facts, and try to do it in a respectful way, because sometimes there's a lot of emotions in all of this. So try to negotiate calmly. It's not easy to do, and we hope to provide you with more tools in the future to support you.
So for primary care physicians, who often are the first to write somebody off of work and to take some time off, often there's never a plan. It's, take some time off, you'll be okay.
Yeah.
What suggestions do you have for that plan? What do we do when somebody starts going off of work?
So the first thing I'll say is that I usually try to avoid stopping work as much as possible, because my patients often don't want to leave their work because they like it. And then you go into deconditioning. So people lose the habit of going to work, and you kind of lose this habit of working, and your self-esteem decreases, your social contacts decrease, your cognitive stimulation decreases. So if it's possible, I try to avoid it, but sometimes it cannot be avoided. And I'll say this, it may take months and even years when you reach this point, but you have to have a plan, and you have to go through all the treatments available. And as soon as possible, go back to work when you improve. But you need a plan for improvement. If not, you're just going to stay there and be at home, and not necessarily better. Some people cannot go back to work. I've seen this, and they find a new life balance with disability, and they can do other activities. But if you go back to work, progressive, you have to uh, improve every trigger there is in your workplace, work with a multidisciplinary team as much as possible, and go slowly progressive. And I'll say this, a lot of my chronic migraine patients cannot go back to 5 days per week. You have to look at 3 to 4 days per week, and often after this line they find that they cannot make it. This happens, and then you need your doctor to advocate for this and try to find a flexible way. When I was young and naive and very pretentious, I used to say I'm going to cure everybody with my magic hands, and I realized that it did not happen. And I don't. You have to find this fine balance between hope and being realistic. And I have a patient who told me, if I had known, I would have never chosen this line of work, or I would have done this way before and be more happy, instead of struggling for 10 years. So those are very sensitive topics. And I hope that we can dig into them a bit more in the future, because this is very, very concrete for people.
Yeah, one of the issues that we do see is a lack of access, and often the only access they get is to a physician writing a prescription, and not access to interdisciplinary programs, which I think we've really tried to show today how important that is in the treatment of chronic illness, including migraine and other headaches. What suggestions do you have for insurance companies, as well as our specialty colleagues, about interdisciplinary care and advocating for such?
Rob, I mean, it's no surprise to you that if you look at the data that was shared today, in this country, there should be numerous multidisciplinary migraine clinics. It should be the standard of care. I think one of the reasons it's not there, it's because there's no business model that allows it, and there's no structure for it. So there's lots of concussion clinics. So why isn't there migraine clinics where people can get a global approach that we've talked about today? So multidisciplinary care is the key, but doctors work in their doctors' offices, psychologists work in their psychologist offices, and academic departments and universities, with few exceptions. So that means people who train neurologists and neurologists, they don't care about headache. I have to say it. I mean, it's a stigmatized specialty. It is evolving, but I think it is still a challenge to get headache a strong part of neurology departments who care more about stroke or epilepsy or multiple sclerosis. Patients can make that change. Patients can unite and do advocacy and go to the College of Physicians of Canada, and they can go to the universities and say, waiting lists for headache are 3 years. This is not acceptable from a public health perspective. Look at this data on migraine, right? And then things can change. But it's true to say that people with migraine have been, stigmatized and isolated. So now we hope to bring them together, break the stigma, and just respectfully take their rightful place and say, why does this person with MS has all this care, and I live with chronic migraine, I have no care at all? So I think this can change, but it will need a lot of teamwork, and it all starts with connections. So I'll thank you again for giving this opportunity to show what migraine care should be, which is teamwork and not only a prescription.
Connections, that's got to be the answer. And I think that, one of the problems with medicine is that we get trained into our small little boxes, and we don't really work together. You don't have psychiatrists and neurologists and internists and primary care physicians working under the same roof and learning from each other.
Absolutely.
Probably the best thing I get out of an interdisciplinary clinic is all the things I learned from everyone else.
That's so true. That's
right.
The only way to get better at something, is to do it. And then from difficult cases, well, you learn everything. But if you don't have a team, it's much more difficult to do that. So it's something I could observe in Calgary. And the patients teach us so much. I mean, I learned through my patients about those Jedi masters, they told me their successes, their struggles, what they tried, what didn't work. The reality is that I swear, as a med student, as a neurology resident, nobody told me that ever. Patients told me. So I think that these patients need to be part of this team. The lived experience is very important. It doesn't mean that it's the only thing. Like, doctors have also their views and points, but I dream about this for a long time now. So maybe someday we'll have a migraine clinic and work all together and do research and all that stuff.
The reality is we need it, and we need more than just one. We need them across the country. Seeing the psychiatrist telling you, "Oh, fix the headache and your depression will get better." Seeing the neurologist and saying, "Fix the depression and the headache will get better." And so this is what happens when we silo, and we really need to end that. And this is part of the public system and the way public healthcare works, and why many people say public healthcare should be the floor, not the ceiling. And so we'll be interested to see what happens as, systems don't want to change, systems don't want to move. And it takes great advocacy from people like you. But we need 100 Liz's around the country in order to really push this. But absolutely, the fact remains, it comes from the people who are struggling to start advocating and pushing. Enough is enough. We represent, as you mentioned, 11%
That's crazy.
of people in Canada. That is a swing vote in an election, and we have to start standing up that way. 20% struggle with chronic pain. That's not just a swing vote. That could determine an election. And yet, when was the last time migraine or chronic pain was on an election platform?
I think it's just like we have to scratch the surface and take the first bite at it. And then it will be easier, because then at present time, people just looking, they feel, everybody tells me they're so isolated. So so now just having this event, just having you and the PSA and partnering is exceptional. So I think there's been great progress. But so guys, look at our Migraine Canada website and you'll hear more about it from our executive director, Wendy. And thank you again, all the PSA team, for a wonderful event.
Thank you so much, Liz. And again, please check out Migraine Canada.